In 1987, Alan A. Jackson at the University of Southampton gave 6 healthy adults 4.10 grams of sodium benzoate by mouth. Benzoate conjugates with glycine in the liver to form hippurate, which the kidneys excrete, a clean, measurable way to drain the metabolic glycine pool. Then Jackson watched. Within 3 hours, 5 of the 6 adults showed a significant rise in urinary 5-oxoproline, the chemical signal that glutathione synthesis is straining because glycine has run short. Jackson was not testing a sick population. He was testing normal adults. He stressed their glycine supply for a few hours with a single compound found in processed food preservatives. And their redox chemistry buckled. He did not frame it this way in 1987. The margin is thin. The non-essential amino acid becomes essential the moment the system is asked to do more than the minimum. Non-essential is a classification of pathway, not of quantity. It means the biosynthetic route exists. In this case, glycine is synthesized primarily from serine through serine hydroxymethyltransferase, a mitochondrial enzyme present in every tissue. It says nothing about whether that route meets demand. There is no formal RDA for glycine. The classification sits in nutrition textbooks unchanged because nobody needed to challenge it when the question was scurvy and rickets and pellagra. Enrique Melendez-Hevia and colleagues, writing in the Journal of Biosciences in 2009, did the arithmetic the textbook never did. For a 70-kilogram human, they estimated that biological demand runs near 15 grams of glycine per day. Endogenous synthesis delivers roughly 3. A modern diet of muscle meat, eggs, and fish delivers another 1.5 to 2. The gap is approximately 10 grams. That figure is not settled nutrition policy. Melendez-Hevia's model is mechanistically coherent and repeatedly cited, but not an official requirement standard. What it is specific. It is precise enough to be wrong. And the joint discussion already described cartilage nutrition through imbibition, which makes that arithmetic not academic. It is the daily supply calculation for every joint surface in your body. Alan Jackson arrived at that uncomfortable middle not by starting with glycine, but by spending years on neonatal nitrogen metabolism and amino acid utilization. At Southampton in the 1980s, he kept encountering the same problem from different directions. The 1987 sodium benzoate experiment had an almost tactile simplicity. 6 normal adults, a single oral dose of 4.10 grams sodium benzoate. The benzoate conjugates with glycine inside the hepatocyte to form hippurate, which the kidney filters cleanly, a deliberate measurable drain on the free glycine pool. Jackson then tracked urinary 5-oxoproline over 6 hours. The signal matters because 5-oxoproline accumulates when glutathione synthesis cannot proceed normally, specifically when glycine availability becomes rate-limiting, and gamma-glutamylcysteine, unable to complete the glutathione cycle, cyclizes into 5-oxoproline instead and spills into urine. 5 of the 6 adults spiked within 3 hours. He was watching a metabolic system that looked adequate become inadequate under a modest chemical stress, and the stress was not exotic. Sodium benzoate is a food preservative found in soft drinks, condiments, and packaged foods. By 1989, Jackson was arguing in print that the distinction between essential and non-essential amino acids was too crude to be useful. By 1991, he had published the claim that would follow him, that only alanine, aspartate, and glutamate are truly non-essential, and that glycine belongs in what he called the conditionally essential category. Amino acids the body can make, but cannot make in sufficient quantity under real physiological demand. Not supplement folklore. A metabolic bookkeeping argument from someone who had spent too long inside isotope studies to accept the textbook category that had never been stress tested. You now know the gap is real. The question changes from whether glycine is scarce to what the body does when it is. What the body does is triage, not a malfunction, the system performing correctly under constraint. When glycine supply falls short of demand, the body ranks its obligations and pays them in survival order. First, heme synthesis. Glycine is a direct substrate for the porphyrin ring, the structure at the center of hemoglobin. Without heme, the red blood cell cannot carry oxygen, and the organism is minutes from failure. That account gets paid first, regardless of what else is short. Second, purine synthesis. Glycine contributes both carbon and nitrogen atoms directly to the purine ring, which means it sits inside DNA and RNA production, the blueprint level of cell renewal. That account gets paid. Third, bile acid conjugation. In most Western adults, glycine-conjugated bile acids predominate over taurine conjugates by approximately 3-to-1. Bile acid conjugation determines the efficiency of fat digestion, cholesterol excretion, and the absorption of fat-soluble vitamins A, D, E, K, and dietary omega-3 fatty acids. That account gets paid. Glycine is also a precursor for creatine, for porphyrins beyond heme, and for glutathione. Those accounts get paid to whatever degree supply allows. Then come the structural accounts: skin, fascia, tendons, ligaments, cartilage, bone matrix, the walls of arteries, the gut barrier, hair and nails. These tissues are collagen dependent, and collagen is glycine at every third residue, not by convention but by geometric necessity, because glycine is the only amino acid small enough to occupy the interior position of the triple helix without disrupting the packing. Collagen accounts for roughly 25 to 30% of total body protein. The structural accounts get paid last because a triage system that sacrificed oxygen transport to maintain skin elasticity would not survive the afternoon. The stiffness you call normal for your age, the tendon that complains after effort you once absorbed without thinking, the skin of your forearm that has lost its architecture. These are not mysteries. They are the predictable output of a resource allocation system doing exactly what it was designed to do, across decades on a modern diet that delivers almost no glycine from connective tissue. McCarty, O'Keefe, and DiNicolantonio mapped this in the Ochsner Journal in 2018. The body does not do miracles democratically. Heme paid, purines paid, bile acids paid, skin deferred. You now know what gets paid first. The question changes from "why am I aging?" to which account has been quietly running short. The redox account is where aging becomes biochemically visible in a way most people do not expect. Glutathione, the body's primary endogenous antioxidant, is a tripeptide of cysteine, glutamate, and glycine. Glutathione synthase, the enzyme completing its final assembly, has a Michaelis constant for glycine that sits above typical tissue glycine concentrations. That means glycine availability is rate-limiting for glutathione synthesis, not an occasional bottleneck, but the structural constraint on how much glutathione the aging body can produce. The margin narrows. The signal spills. When glycine runs short, gamma-glutamylcysteine cannot complete the glutathione cycle. Instead, it cyclizes into 5L-oxoproline, the same signal Jackson was measuring in 1987 using sodium benzoate as a proxy stressor. In 1996, Jackson's group reported that vegetarians and adults on low-protein diets excreted significantly more 5-oxoproline than omnivores, suggesting that ordinary dietary patterns in free-living adults can leave glycine-dependent pathways chronically underprovided. The inflammation discussion already separated turning the immune system on from turning it off. Glutathione is part of the infrastructure that turns it off, clearing reactive oxygen species, supporting detoxification of xenobiotics, maintaining the redox environment inside immune cells. Plasma glutathione levels fall by approximately 50% between young adulthood and age 60. That is not an incidental finding. It is the chemistry underneath the person who feels wrecked by a single glass of wine, who recovers from illness more slowly, who does not handle medication the way they once did. They are not suddenly more sensitive. They are operating with a smaller redox margin, and the rate-limiting input for rebuilding that margin is a 10 gram per day structural shortage. Rajagopal Sekhar and colleagues at Baylor College of Medicine, publishing as Kumar et al. In 2023, randomized 24 older adults to 16 weeks of Glynac, glycine combined with N-acetylcysteine. Glutathione deficiency improved, oxidative stress reduced, mitochondrial function improved, gait speed, endothelial function, systolic blood pressure, and molecular hallmarks of aging all moved in the same direction. 24 subjects. The caveat is real. The observation stands. Older humans can be running metabolically tighter than any standard panel reveals. You now know the redox margin is thin. The question changes from why don't I recover the way I used to what the recovery system is actually running on. The structural account is the most visible one, which is why most people who find this story find it through skin or joints rather than through Jackson's urine data. Collagen is the most abundant protein in the human body. It sits in every tissue already named in the triage section: skin, fascia, tendons, ligaments, cartilage, bone matrix, arterial walls, gut lining, and its structural integrity depends on glycine at every third position of the triple helix. That placement is not interchangeable. The helix cannot form correctly with any other amino acid in that interior slot, because glycine is the only one without a side chain, and the packing geometry of the triple helix requires exactly that absence. The gut discussion already showed that barrier tissues fail quietly before they fail dramatically, and the gut barrier is collagen-dependent in precisely the same way as the arterial wall and the joint surface. Patricia de Paz Lugo and colleagues published a chondrocyte study in 2018 in PLOS One. Bovine articular chondrocytes were cultured for 15 days. Amino acids were added in a concentration range from 0.25 to 7.0 millimolar. Type 2 collagen production was measured by ELISA every 48 hours. At 1.5 millimolar glycine, collagen synthesis rose to approximately 225% of control. It is in vitro, bovine cells, not a human knee trial, and that distinction matters. But the image is clean. Give the cell line more glycine and the collagen curve climbs. Martin Wheeler and colleagues in 1999 described glycine as a new anti-inflammatory immunonutrient. The mechanism: glycine receptors on macrophages, Kupffer cells, and other resident immune cells damp calcium influx, blunt NF-κB signaling, reduce superoxide generation, and lower cytokine production. The systematic reviews of collagen peptide trials, Campos et al. In 2023, Khatri et al. In 2021, report improvements in skin hydration, elasticity, wrinkles, joint pain, and functional scores at 5 to 15 grams per day over 8 to 24 weeks. Small studies, heterogeneous populations, commercial funding in many trials, and the direction is consistent. You now know the structural account. The question changes from why is my skin thinner to what the skin and every other collagen-dependent tissue was waiting for. The sleep account is where the popular version of this story goes wrong before it goes right. The popular account says glycine supports GABA production. GABA is synthesized from glutamate, not from glycine. That link is not established. What is established is different and more specific. Glycine is itself an inhibitory neurotransmitter, one of the primary inhibitory signals in the spinal cord and brainstem, operating through strychnine-sensitive glycine receptors that are distinct from GABA-A receptors. It is also a co-agonist at NMDA receptors, including those in the suprachiasmatic nucleus, the circadian pacemaker. The sleep discussion already mapped how core body temperature must fall for sleep onset. A drop of approximately 1 degree Celsius in the 90 minutes before sleep is part of the physiological preparation for sleep architecture. Glycine appears to facilitate that thermal descent through peripheral vasodilation. Increased cutaneous blood flow dissipates core heat, lowering core body temperature and accelerating the transition into non-REM sleep. Makoto Banai and Nobuhiro Kawai reviewed the human and animal data in 2012 in Sleep and Biological Rhythms. The human crossover trial, 10 healthy men in a sleep restriction protocol, 7 analyzed after exclusions, time in bed reduced from an average 7.3 hours to 5.5 hours. 3 grams glycine or placebo taken 30 minutes before bedtime for 3 nights. Glycine reduced next day subjective fatigue. Improved psychomotor vigilance task performance. The rat mechanistic work was more detailed. Exogenous glycine increased plasma and cerebrospinal fluid glycine concentrations, increased cutaneous blood flow, lowered core body temperature, and shortened non-REM sleep latency. The action appeared to run through NMDA receptors in the shell of the suprachiasmatic nucleus. Yamadera and colleagues in 2007, Inagawa and colleagues in 2012, Kawai and colleagues in 2015. The same group, the same compound, the same direction. Small trials, 7 subjects in the primary human crossover. Modest effect sizes. Glycine is not a sedative. It does not produce the pharmacological force of a Z drug. What it produces is a nudge toward physiologic sleep architecture. Lower next-day fatigue, cleaner vigilance after restricted sleep. The wired feeling at 10 p.m. that arrives reliably and without obvious cause is not always cortisol and screen exposure. Sometimes it is the inhibitory chemistry and thermoregulatory mechanism running on short substrate. Before the protocol, the evidence deserves placement on its actual shelves. Glycine's molecular roles in heme, purine synthesis, bile acid conjugation, glutathione, and collagen structure are not contested. Established at the biochemical level, replicated, mechanism understood. The 10-gram daily deficit model is mechanistically coherent and repeatedly cited, but model-based, not an official requirement standard. Plausible, not settled. Jackson's 5-oxoproline work sits at the border. The biochemistry is real. The depletion experiment is real. The vegetarian urinary signal is real. But translating those findings into a universal diagnosis of glycine deficiency in free-living adults is a larger claim than the papers themselves make. The sleep effect of 3 grams before bed has human crossover data and animal mechanisms behind it, and small samples in front of it, plausible to moderately supported. Immune modulation through glycine receptors is established in cell and animal models. Its clinical translation in aging humans remains plausible, not finished. GlyNAC is the strongest human aging signal in this literature, and the trial was 24 people. Anyone who presents this as settled anti-aging science has collapsed the tiers. Anyone who dismisses it because it is not yet a clinical guideline has made the opposite error. None of those systems is foolish. They are what medicine does when the visible failure has already arrived in the face, the joint, the sleep record, or the lab panel. First, the cosmetic branch. Hyaluronic acid fillers at an average physician fee of approximately $715 per syringe, according to American Society of Plastic Surgeons data. Laser resurfacing, skin boosters, topical retinoids, the entire language of rejuvenation applied to tissues that are downstream of a supply chain problem. Then the orthopedic ladder. Physical therapy, imaging, corticosteroid injections, platelet-rich plasma, and eventually the knee replacement whose U.S. cost ranges from roughly $15,000 to $75,000 depending on setting and insurance coverage. Then the sleep branch. Melatonin, low-dose doxepin, and in the wrong patient, benzodiazepines or Z-drugs, geriatric prescribing guidelines consistently warning about falls, delirium, cognitive effects, and fracture risk in adults over 65. Then the antioxidant branch, IV glutathione clinics offering drips or injections session by session, as if the redox system were a membership service rather than a biosynthetic pathway. The body's version, glycine to build collagen, conjugate bile acids, support glutathione synthesis, produce heme, and facilitate the thermal descent into sleep. 3 grams at bedtime is not the same dose, immediacy, or potency as a syringe of filler or a total joint replacement. It is slower by weeks, upstream by decades, and less dramatic. The hardest outcome data sits in cardiovascular medicine. In 2015, Yunpeng Ding, Gard Svingen, Eva Pedersen, and colleagues at the University of Bergen published a prospective cohort study in the Journal of the American Heart Association. 4,109 patients undergoing coronary angiography for suspected stable angina. Median follow-up of 7.4 years. 616 patients, 15%, experienced an acute myocardial infarction. After multivariable adjustment, each standard deviation increase in baseline plasma glycine corresponded to a hazard ratio of 0.89 for AMI. In 2019, Laurel Wittemans and colleagues published a Mendelian randomization analysis in Nature Communications using glycine GWAS data from up to 80,003 participants and coronary heart disease data from up to 88,800 cases and 485,266 controls. Each standard deviation increase in genetically predicted glycine corresponded to an odds ratio of 0.95 for CHD, with blood pressure as a likely mediating pathway. Observational design, possible genetic pleiotropy, messy metabolite networks. The direction across both study designs is nevertheless consistent. Lower circulating glycine tracks with worse cardiometabolic outcomes, and higher glycine looks protective. For most of human history, animal eating was nose to tail by necessity. Skin, tendon, cartilage, marrow, joints, trachea, fish skin, chicken skin, the collagen-rich fractions modern food culture has engineered out of the plate because they are tough, unfashionable, or inconvenient to process. The grandmother's broth that simmered for 6 hours and set solid in the refrigerator overnight, collagen at approximately 3 grams per 100 milliliters of properly made bone broth, gels below 35 degrees Celsius, was glycine in solution. Then modern food abundance arrived, and the tender cut became the desirable cut, and the connective tissue fraction became the discard. The developmental version is sharper. Children raised on boneless breast meat, chicken nuggets, fish fillets, protein shakes, and burgers. Very few eating the skin on the fish, the cartilage at the end of the bone, the slow-cooked shank. Then decades later, surprised that tendons fail under load, that skin thins, that recovery feels perpetually underfunded. The body did not become alien. The menu did. The protocol, as I run it, is built around restoration rather than supplementation. Morning. 10 to 15 grams of hydrolyzed collagen peptides dissolved in coffee or mixed into a shake, or the food first version, which is broth made from bones and connective tissue, oxtail, chicken feet, fish skin, slow-cooked shank, the parts of the animal that carry collagen load. The collagen must be paired with vitamin C, because the hydroxylation of proline and lysine residues, the step that cross-links collagen into functional structure, is ascorbate dependent. No ascorbate, no mature collagen, regardless of glycine supply. That means citrus, kiwi, peppers, or a modest supplement alongside the collagen source. Night. 3 grams of pure glycine dissolved in water, 30 to 60 minutes before bed. That is the dose used in the Banai and Kauai human trial, not the dose of a sleep pharmaceutical, the dose of a missing inhibitory substrate. 3 grams of glycine sits on my nightstand now. It has since I read the Banai trial, not because the effect size is large, which it is not, but because I recognize the mechanism and because I had already noticed that the wired feeling at 10 p.m. did not respond to the interventions I had tried. I sleep in the same bed. The mechanism changed what happened in it. For connective tissue, the commitment is longer. The systematic reviews that showed improvements in skin and joint outcomes used 5 to 15 grams per day over 8 to 24 weeks. Week 1 is usually subtle. Less bedtime tension, perhaps slightly deeper sleep, sometimes better tolerance of fattier meals as bile acid conjugation runs a little more fluidly. By week 4, recovery begins to feel less brittle, fewer random tendon complaints, a little less of the dry paper stiffness in the morning that used to require 20 minutes to clear. By week 8, the change, if it comes, tends to arrive as resilience rather than drama. Fewer small strains, better tolerance for load, less of the sense that the body is fraying at its edges and cannot keep up with its own repair schedule. One contraindication: people with advanced kidney disease or rare congenital disorders of glycine metabolism should not self-prescribe high-dose amino acid regimens without direct medical guidance. Return to where this started. Jackson's 6 adults, the sodium benzoate, the 3-hour window, the 5 of 6 who spiked. The finding was not dramatic by clinical standards. Nobody was hospitalized. No organ failed. No acute event followed. What failed was the margin. The margin that glutathione synthesis requires to run normally. The margin that collagen turnover draws on every day in skin and tendon and cartilage and gut barrier and arterial wall. The margin that the inhibitory chemistry of sleep uses to facilitate the thermal descent at 10 p.m. The body paid its essential accounts and deferred the rest. Jackson demonstrated that this deferral can be induced in normal, healthy adults in 3 hours with a preservative. What decades of modern eating, lean toward muscle and away from connective tissue, has done to the structural account is a longer version of the same arithmetic. The body did not fail. It paid what it had to pay, in the order's survival required, for as long as the supply ran short. The structural tissues drew the deferred account. The question is not whether you are aging. The question is whether what you are calling aging has another name.